This is Legal Nurse Podcast, the first ever podcast specifically for legal nurse consultants. You'll learn tips, tricks, and strategies that you can use in your LNC career. If you'd love to hold a book in your hands that you helped to write, be sure to pay attention to the information that I share with you during this show. I am Pat Iyer, the host of your show. This podcast is something that I started in September of 2016 as a way to connect with nurses who have this weird passion that we've got of loving to solve puzzles, dig into the details, be analytical, and write and communicate our expertise. Today, we're going to focus on one of the causes of liability, particularly in acute care settings, where this most often occurs, but could occur anywhere, honestly. Our speaker today is a seasoned nurse with critical care experience. She has expertise working in management, in nursing homes, in med-surg and outpatient settings, most currently in critical care, and she's a critical care expert witness. She has a wealth of experience from working in all of those venues that have brought her perspective of nursing to the point where she is fascinated, as we all are, on working on medical cases. Please meet Yulianna Fedorchak.
Thank you, Pat.
Our topic is on the rapid response team. And I know that that phrase is not going to be familiar to everyone. So let's start first off with what is a rapid response team?
A rapid response team is healthcare providers who are on call at all times for patient emergencies. It is similar to a code and arrest team, but it differs in the sense that we look to prevent the code or the arrest. We look to kind of divert and send the patient to critical care before they arrest, or intervene before they decompensate. Members of the code or the team typically include a pharmacist, a doctor, and there's typically a lot more involved in an arrest team. But the rapid response team is a nurse, a physician, and a respiratory therapist. There are different variations of those, and sometimes all three respond, sometimes two respond, but at least two people need to come when a nurse or a family member calls a rapid response.
Tell us about the circumstances that would lead a nurse to activate the rapid response team.
There's multiple criteria when to call a rapid response team. Typically, a nurse would call a rapid response team if the patient is tachycardic or bradycardic. So if their heart rate is above 140 or below 40, if their blood pressure is crazy out of their normal range, but if you're a normal walking and talking adult and your blood pressure is typically normal, anything above 160 or below a systolic blood pressure of 90 would prompt a nurse to call. Oxygen saturation below 90, especially with supplementation, especially if you do not have COPD or any underlying pulmonary disease, seizures, uncontrolled pain, and my personal favorite is the gut instinct of a nurse. If you see that your patient is decompensating, if you see it's your second shift today and they look very, very different to you than they did yesterday, we always encourage nurses to be proactive and call a rapid response team and get that patient evaluated. Whether they are being evaluated by the rapid response team or their resident, it really doesn't matter, or their primary physician. It won't make a difference. We can, on the rapid response team, we can typically respond a lot faster than a physician, and we can intervene a lot faster and, collaboratively work with their physician and get the patient the care that they need before they are at that point of no return where we have to do resuscitation efforts and cardiac arrests happen.
It occurs to me as I listen to you, and I know you've been in nursing for a while. Are you aware of any resistance from healthcare providers to the concept of a rapid response team and putting that amount of responsibility in the hands of a nurse?
Columbia's rapid response team is very new. I would say very new, mostly because it's about 7 years old. In the beginning, there was quite a bit of resistance because it is a nurse-led team. You don't know these nurses. They're, strangers to you, and you don't really work with them every day. You don't have the rapport, and you don't have that trusting relationship. Once the nurses on the rapid response team built that relationship with providers, with other nurses, I noticed there's so much less resistance. They're more open, and they see you more of it as a colleague, as somebody, as a resource that's going to really help you and make your day better and make your patients' hospital stay better. So it's definitely, a give and take. If you have a good relationship with the providers, they will be more likely to call you. That's why it's very, very important to build those relationships.
And you mentioned earlier that the nurse or a family member can call the rapid response team. And I know for some people listening, the idea of the family being able to pick up the phone and bring an emergency team to the bedside might strike them as either very empowering for family members, or would they abuse this because the patient needs a bedpan and nobody's answering the call light and they call the rapid response team? I mean, tell us about how healthcare providers prepare family members for when it's appropriate to activate this resource.
Many hospitals actually have a family member brochure with the rapid response team number and why you would call a rapid response team. Yes, there's a great deal of concern that a family member will call for a bedpan and call the rapid response team. Actually, I interviewed recently for a nurse practitioner position in a rapid response team in a local hospital, and they do not allow family members to call because they are in what you would say more of a upscale area, and they feel that their family members would really call a rapid response team for anything down to a bedpan. It does not happen like that. Typically, if the family member is educated that this is for patient emergencies, if they feel that their loved one is in danger, if they feel that something is going on, if they have that gut feeling that something's really going to happen, especially in the pediatric units. Parents usually know their kids better than their providers do. In the hospital, in acute care, the provider knows that child for a day or two while the parents are there all the time. So it is very, very useful to have this kind of tool because the parent can comfortably pick up the phone and call and get a set of eyes. There's really no harm being done, especially when it comes to the care of a child. If something were to happen to that child, it would be on the nursing staff. And I know myself and every nurse out there, we care for our patients and we want what's best for our patients. So we allow families to call rapid response teams, and typically they are very, very good at calling when something's actually happening. A patient fall, blood pressure is too low, or they feel dizzy, or a seizure. And sometimes that call bell doesn't get the fast response that you need. And there are studies out there that say that patient families actually call rapid responses less frequently than nurses. And typically they call for a good reason. There are very, very few rapid responses that are called by families that are without a reason.
It sounds like there's some fear holding back the administration of that hospital that you're describing, who resists the idea. I would have thought, Yulianna, that you would say that this was located in a poor urban area with family members who are likely to be uneducated and would take advantage of the system. But you're describing just the opposite, with more likely well-educated people who should be able to differentiate between my father is in extreme pain versus this is unusual pain that is not going away and somebody needs to do something.
Sometimes I think as we know more, as we have more information, and we have more privilege, we are more likely to use hospital staff as almost wait staff. And I think that that's kind of what this hospital was aiming at, was typically they will be the ones, these patient families will be the ones that will hit the call bell for no reason, or just expect a great deal more from nursing staff that is not part of the nursing staff responsibility.
Well, backing up to the idea of prevention, because no one wants to intervene in an emergency if they can intervene sooner. We have, just historically, and I've been in nursing a long time, so I've seen these evolutions. Code teams deal with the emergency. Rapid response teams were designed, as an interesting point, by a nurse in New Zealand who I heard speak at a conference when I was teaching in Australia one year. She was a critical care nurse, and she felt that patients would do better if we could intervene sooner, before they had gotten into such massive amount of trouble. And she encountered a lot of resistance, but was very determined, and was the person who put this idea forth. And from one person in a critical care unit in New Zealand, we're sitting here 20 years later with rapid response teams being a fairly common phenomena, not universally available in this country for sure, and probably not universally available in other countries. But if you take it one step backwards, you would love to be able to not have to call the rapid response team by recognizing changes in the patient before the team is necessary. Tell us about how we can get at that prevention concept. And of course, this also impacts our analysis of liability as legal nurse consultants, because we are often asked to backtrack. What were the symptoms leading up to the need for the rapid response team? What were the changes in the patient's condition? How often was that person being monitored? Were the changes being reported? Was the nurse going up the chain of command to bring in the appropriate provider to take care of the deteriorating condition? Now, that was a very long question. And the beginning of it was, tell us about prevention. How can we get to look at the analysis piece, and what aspects of prevention should we be focusing on? Before we continue, let me ask you a question. I love action takers. They are the LNCs who implement what they learn. When you invest in the Medical Records Analysis Compilation Book team, we both win. You win because you get more visibility and authority, you have fun, and you network with your co-authors. When you join the team of authors writing their chapters for Medical Record Analysis, 3rd volume, you will receive concrete help with figuring out what you should write your chapter about. You'll have answers to your questions. You'll have a clear sense of direction. You'll get to know other LNC co-authors. We are a rare breed. I win because it helps you, my client. Pretty sweet. But there is a catch. The catch is that the chance to become one of our authors is only available to you if you sign up before 11:59 p.m. Eastern Time on July 30th, 2024. After that, you'll have to wait a year for the chance to come again. Here's a recap of what you get. A self-paced course to teach you how to structure and write your chapter, 1,500 to 2,000 words. So there's no guesswork, and you'll be using a proven system. You'll have a meeting with me to discuss the focus of your chapter so that you know how to get started. A complete publishing package that includes editing, formatting, cover design, and placing the book on Amazon. I do all of this. A virtual book launch event where you can invite a guest to learn more about your book. You'll also have a collaborative relationship with your co-authors. When they market the book, you gain visibility to their audience. You'll have a complimentary copy of the book and the opportunity to purchase them at a 50% discount over the retail price in multiples of 10. You can give away those books or resell them when you're exhibiting or have them for sale on your website. You have also the opportunity to be a podcast guest, to have a spot on Legal Nurse Podcast for worldwide exposure. My podcast has listeners in 107 countries. The podcast audio and video files are sent to you. You can post them anywhere you like. But you must take action by July 30th at 11:59 p.m. Eastern to get into this project. To join us, go to lnc.tips/MRA3. And now let's return to the show.
I was actually part of the team that built Columbia's rapid response team. We were focusing just on that, prevention. Rapid response is great when you get the call and the patient is decompensating, but they have not coded yet. What if you could prevent even the rapid response? So as nurses, we were looking for ways to build relationships with the hospital staff. Our rapid response team at this point in time only covers the adult areas. So what we actually did, we found that as rapid response nurses, we would take the responsibility upon ourselves and we would walk around the units. We would take the time and we would meet with every charge nurse on every shift from all 30 plus medical surgical units and step downs at Columbia Presbyterian. And we would sit down and spend a couple of minutes and ask them who they felt was at risk of becoming a rapid response, who they felt needed that little bit of extra care. And then we would actually go into the patient room, introduce ourselves, and take a look at our patient, their patient ourselves. We are critical care nurses, and them as med-surg nurses, they loved having that resource. They still love having that resource because sometimes, in the medical surgical world, in the step down world, you have so many more patients and you're being pulled in so many more directions. They have that resource. They pick up the phone, they call the rapid response nurse and go, hey, I don't know, they just look weird. They're not at a rapid response level just yet, but can you come down and look at them? They have a fever. They had a seizure last night, but right now they're obtunded. Or maybe it's, I don't have IV access to hang these antibiotics for this septic patient. Can you come and help me? Having that outreach for us at Columbia was very, very rewarding as nurses, but also it decreased the numbers of rapid responses called in a day. There would be days that I would just round on the units, talk to the staff, and I would have no rapid responses. And that's, in my mind, that's crazy because when you have 30-something units, there's not one patient that decompensates in a 12-hour shift in a whole hospital. It is so rewarding and it is so great for patient care. Patients feel cared for, families feel connected. You have that relationship with everybody on the team. And to me, that was the best thing that we could do with the rapid response team. And as far as liability, you decrease your liability by just picking up the phone and kind of calling a friend and going, hey, I know you have more skill, a different set of skills than I do. So can you come look at this? Can you tell me if I'm missing something? And that back and forth relationship prevents so many patient injuries, prevents so many codes and rapid responses. And personally, 5 years later, this team is still functional and it's still doing the same thing. We've gotten to the point where I do in-services on any unit when a nurse asks me about a device, transvenous pacemakers. So many units do not get transvenous pacemakers, and once in a blue, they'll get a transvenous pacemaker on acute rehab. And I'll pick up a transvenous pacemaker and go show them the settings, go show them how to use it, how to check it, what you need to do. And we've improved patient safety so much by just going that extra mile and building those relationships and being healthcare providers and caring for our patients.
You sound like a wonderful resource. We would need to clone you and spread you throughout the world.
Oh, I wish I could help teach so many more nurses to do this.
I spent 7 years as a director of the staff development department, and one of the common phrases that we would share within the department was, in describing inexperienced nurses in particular, you don't know what you don't know. How often do you encounter people to ask for your help, or they tell you afterwards they were reluctant because they feared that they would be chastised or rebuked or, in some way demeaned because they said, I need help and I don't know what's going on with this patient?
Again, at Columbia, we try to make this a very open relationship and make sure that all the nurses know that you will not be chastised, you will not be criticized if you just pick up the phone, even if you call a rapid response and it was not a rapid response. I know that there's different environments and different hospitals, and I came from a different place. My prior experience is that I was chastised. So we try to go that extra mile. We try to make sure that the staff is comfortable with us because we understand, even as providers, as even our colleague doctors, we understand that they are so much more likely to call for help when they, at the beginning of an event, at the beginning, when that patient starts decompensating, when that patient gets actually sick. And it helps so much to prevent these adverse events. Other hospitals, I hope will get on board. I hope we're able to change the culture when it comes to asking for help. None of us are perfect. We are not expected to know everything. But when we work together as a team, each of us comes from such a different background, gives everybody such a different point of view. You're able to put all of that together and work towards something so much more positive than if you could have you stood there alone and waited for something to happen to your patient because you were afraid to call.
Mm-hmm. As we bring this into the realm of analyzing cases that are focused on a theme of a failure to rescue or a delay in rescuing the patient, what are some of the liability issues that would arise as we're looking at charts?
Firstly, I've reviewed quite a few cases when it comes to cardiac arrests and failure to diagnose. The first theme that I always see is lack of documentation. Lack of documentation in code events, lack of documentation in rapid response events. And, we have this phrase in nursing where if it wasn't charted, it wasn't done. But I try to remind all nurses as we go through this education process at Columbia, I try to remind everybody is, please remember, not only if it wasn't documented, it wasn't done, 5 years later, if this comes up, you will not remember what you did. And you always want to put your best foot forward. You are there caring for that patient. You want to make sure that everything that you did is documented. You want to make sure that that code is appropriately translates on paper, because when that patient, God forbid, dies, questions arise from families, questions arise from other healthcare providers, and you want to be able to answer those questions comfortably and not feel like you're being attacked because your documentation wasn't there and you don't remember it. Second, I see a great deal, just say, lack of education when it comes to what a functional code team or a rapid response team. There are so many charts that I have seen that one provider will say, well, this person did not do what they were supposed to do.
In writing in the chart, huh?
Right directly in the chart. And then the other person will write, they will write their note. And then 2 days later, they will realize what was written in the chart and add an addendum. And you really don't want to be doing that. You always want to be on the same page. You always want to kind of have that communication. You want the camaraderie when it comes to patient care, when it comes to the liability aspect of this. And you also want to make sure you're doing everything that you're supposed to be doing. You want to make sure, especially, whether it's a rural hospital or a teaching hospital like Columbia, you will see so many things. And nurses don't always realize that they need to keep learning. You need to keep studying. You need to keep understanding the new concepts, the new devices, new disease processes. There are so many new diseases coming forth, and there's so much new research. And in a place like Columbia, that your doctors are constantly publishing new articles, so you're constantly thrown into that. You have access to that information, so you continue learning. In a rural hospital, I worked in an ER in a rural hospital. You don't always get that, but you need to go out there and learn those things, because when it comes to patient care, you need to know the most recent information. You need to know the standards. You need to understand the standards. To be a great healthcare provider, you need to know what you're doing, because it's a person's life that you're holding in your hands. And whether you're missing documentation, or you don't really understand how the ACLS protocol works, or you don't really understand when a patient really decompensates, you really need to constantly be bettering yourself, because we live in America. Liability is extremely, extremely important everywhere. But in America, chances are in your nursing career or your medical career, you will be sued, because we focus so much on making sure that everything is done correctly, making sure that our patients are protected the right way. So if you're on top of everything, if you're making sure that everything is correct and making sure that your documentation is in line with what it should be, and making sure that, maybe, okay, we're all human. This code did not go as well as I wanted it to go. Let's go back. Let's huddle about it. Let's discuss it. Let's make the next code better. It's always about growing. It's always about being a better provider for patients.
And you brought up a good point that I hadn't considered, which is in the context of this, clinical areas that do not have frequent codes need to keep their skills intact and do mock drills, do mock codes on busy med-surg units where rapid response teams and cardiac arrests are more common than a huddle going through how did it run, was there any breakdown in communication, were we missing any medications? That kind of conversation has more opportunities to develop generically versus in, say, an OB labor and delivery unit where codes are infrequent, at least for adults. Those nurses can be frozen and not know what to do, not know the basic responsibilities. And if they don't have reminders, they're not going to be able to perform well at an emergency.
I agree with you on that 100%. When I managed interventional radiology, those nurses do not see codes. Those doctors do not see codes. The handful of codes that I witnessed there, very hands-off. Let's wait for the code team. It takes 3 minutes for the code team to arrive. You need to be on that chest, doing compressions, making sure that patient is oxygenating, and being proactive. So as a manager on interventional radiology, I actually implemented a monthly mock code and huddles to make sure that they knew what was going on and to make sure that they were comfortable in their skill set. These weren't novice nurses. They were nurses that had 20 years of ICU experience, but they have been so far detached from critical care, 10, 15 years in IR, you forget all those things. You don't practice it, you don't use it. The new protocols, the code cart looks different. They wouldn't even know where the medications would be located in the code cart. They needed somebody to really do a refresher. And once I started doing these refreshers, they were so much more confident in their own skills to say, okay, if this happens, I will be able to do this. Because when I walked in initially, it was It was very, very, for me, it was scary because I would never want to be a patient there because if something happened, they wouldn't know what to do.
Yes. Yes. You know, we've covered a lot on this topic. I know there's a lot more to cover, but we've run out of time. I appreciate you sharing your knowledge, and I know that there'll be people who are watching this podcast on our YouTube channel, Legal Nurse Business, or listening to it on our audio platforms. They're going to want to know, how do I reach that nurse? What would be the best way for them to be able to connect with you?
I always provide my cell phone number. So my cell phone number is 973-879-2782. I also have a website. It's Dedicated Legal Nurse Consulting. So it's dedicatedlnc.com. I am always reachable by my cell phone 24/7 as needed, though.
And if you have a case in which you need an expert witness with a critical care background, and specifically rapid response teams and their responsibilities and the circumstances that lead up to the need for a rapid response team, keep Yulianna in mind. Thank you so much for being part of this podcast. I appreciate your passion and enthusiasm for what you're doing.
Thank you so much, Pat, for having me.
And for you who's been listening to this, be sure to go to legalnursebusiness.com. We have free special reports on a variety of topics that you can download onto your computer or onto your phone and gain some valuable tips. I will see you on the next podcast. Coming up next on Legal Nurse Podcast, we're going to take a look at article writing for legal nurse consultants. This is one of the best ways for you to get visibility and build up your credibility and authority on a particular topic, whether you're writing for nurses, legal nurse consultants, or attorneys. In this podcast, I'll share with you some tips on identifying what to write about, different styles of articles, and how you can put together an outline or a mind map that will make the writing process much easier. We'll talk about submitting that article for publication and how to respond if the editor sends your article out for reviewers to comment on. That's all covered in the next episode of Legal Nurse Podcast. I'll see you there. That's all for today. Be sure to check out this opportunity that I'm offering for a limited period. You'll have a chance to be part of a team of LNCs who are working together and sharing their wisdom by writing chapters for my next compilation book. Go to lnc.tips/MRA3. That's lnc.tips/MRA3.